Hello, my name is Shay Hebert, and I'm here to give you a presentation called Splitting Schizo Hairs. In this presentation, we will be talking about three of the psychotic disorders. It's not the only three, but it's three bigger ones called schizophrenia, schizoaffective disorder, and schizophreniform. In this video, I will give you the definition of what a psychotic disorder is, the explanation of the diagnostic criteria and associated features for schizophrenia, schizoaffective, and schizophreniform disorders. We will discuss the prevalence, the development of course taken, and the prognostic factors of diagnosing and developing the treatment plan of each of these three disorders. We will discuss the differences of schizophrenia, schizoaffective disorder, and schizophreniform disorder, and I will explain why it is important to have specifiers and modifiers present in the listing of the diagnoses of these disorders. Firstly, I want to explain what is a psychotic disorder. A psychotic disorder is an abnormality in one of these five areas. The first area is delusions. Delusions are beliefs that cannot be changed in light of conflicting evidence. The second area is hallucinations. Hallucinations are perception-like experiences that affect one or more of a person's sensory processes, with the most common sensory process affected being the auditory sense. Disorganized thinking is the third area, and this usually means speech that is hard to follow or understand. The fourth area is disorganized or abnormal motor behavior. This can include catatonia, or any behavior that grossly impedes a person from performing the activities of their daily life. Some of the negative symptoms for schizophrenia are less common, but they're less common in schizophrenia than they are in other psychotic disorders. I'm sorry, I said that backward. They are more prevalent in schizophrenia, but less common in other psychotic disorders. This means reduced expression of emotions and the use of body language. Also, avolition, which is lacking self-initiation in activities. On the next slide, we're going to talk about the diagnostic criteria and associated features of schizophreniform, schizophrenia, and schizoaffective disorder. So in this first bubble of my Venn diagram, it lists the diagnostic criteria in light brown font of schizophreniform. Schizophreniform diagnostic criteria means that it lasts at least 1 month, but less than 6 months, and 2 or more of the diagnostic criteria that I talked about on the previous slide are present. For schizophrenia, the diagnostic criteria are 2 or more of the diagnostic criteria are present, and level of functioning is impacted, and there are continuous signs of symptoms for at least 6 months. Schizophreniform and schizophrenia share that there's no major manic or depressive episode within their active phases. For schizoaffective disorder, there are uninterrupted periods of illness consistent with criterion A of schizophrenia. A major mood episode is present most of the duration. Delusions and hallucinations for 2 or more weeks are present in the absence of major mood episodes. Something that all three share are that there should be no evidence of substance use before making a diagnosis. And associated features listed down here in black is that there are no laboratory or psychometric tests for these three disorders. In each of these bubbles, I have some black font. So over here on the left side, it says restricted social contact, difficulties with self-care, and negative symptoms are less common. These are the associated features of schizoaffective disorder. On the right-hand side, it says that the associated features for schizophrenia are dysphoric mood, deficits in language and executive functioning, and aggression is more prevalent if there is past history of violence or trauma. On slide 5, we're going to talk about the prevalence, development, prognostic factors, diagnosing, and treatment plans for each of these 3 psychotic disorders. For schizophreniform, a third of individuals recover within 6 months. Prevalence is lower than schizophrenia, and there is an increased risk of schizophreniform if your relatives have had it. It's distinguished by its duration. In schizophrenia, 0.3% to 0.7% variation over a 5-fold range, which is a very small scale. Presence of delusions, recognition of signs and symptoms over a period of time. The environment can increase the risk for schizophrenia, and the client may have prodromal and residual symptoms after the episodes have passed. Prodromal would be before the episodes come on, and residual would be after. Something that schizophreniform and schizophrenia share is that the onset can happen in late teens to early 20s, and they exhibit psychotic and cognitive symptoms. For schizoaffective disorder in the bottom circle, the development can happen in early adulthood, and it is a third as common as schizophrenia, and there's a higher percentage in women than in men. There are 2 types of schizoaffective disorder. There's a bipolar type and depressive type. Diagnostic features for schizoaffective disorder include meeting not only criteria A for schizophrenia, but also must include pervasive depressed mood for majority of duration of illness. Like I stated on the previous slide, they happen in waves. There's hallucinations and delusions, and then there's the depressive mood, and then there's hallucinations and delusions, and then there's depressive mood. The prognostic factors are there is an increased risk of schizoaffective disorder in first-degree relatives. Something that schizoaffective and schizophrenia share is that in treatment planning, the client will be placed on mood stabilizers. Schizophrenia and schizoaffective disorder share psychotic, cognitive, and mania symptoms during an episode. Schizophreniform and schizoaffective disorder, the treatments can change depending on the state of the illness that the client is in. All 3 disorders share cognitive behavioral therapy as a treatment plan, antipsychotic medication, other therapies, and social supports as treatment plans. On the next slide, we're going to talk about the differences of schizophrenia, schizoaffective disorder, and schizophreniform. So the difference is that schizophreniform is pretty much the very first step that a client would have to work through. Schizophreniform is the onset of symptoms, or the prodromal phase, the active phase, and then the residual phase. And all of these need to happen at least 1 month, but less than 6 months for it to be schizophreniform. During the first 6 months, or 6 months plus, you can diagnose your client with schizophrenia if the symptoms have appeared that long. There must be a clear presence of one of the first 3 diagnostic criteria: delusions, hallucinations, and disorganized speech. Schizoaffective disorder happens during the uninterrupted period of illness where the client displays active psychotic symptoms. There are also major mood episodes, such as major depression or manic episodes. Depression is also present for the majority of the total duration of the symptoms. Some information on specifiers and modifiers and why they are important to clinicians. Specifiers give the types, severity, and episode number of the episodes of the clients for clinicians. Specifiers are important to the listing of the diagnosis because it lets other clinicians and health providers know the specified type of diagnoses of the client and other information like the occurrence number of episodes. Modifiers are important because it gives clinicians the services codes and also tracking for treatment plans. Modifiers allow clinicians to enter modifiers in the form of codes for billing purposes. It also allows for transparency of services offered and used on the client. Lastly, modifiers help to track data in order for clinicians to accurately form treatment plans. Both are necessary for accuracy and longevity of treatment. I enjoyed this assignment and I hope you enjoyed it too. Thank you. For my references for this project, I used Dr. Marks's YouTube video over what is schizoaffective disorder. Is it worse than bipolar disorder? I took a bunch of notes from there and condensed them down into my slideshow. I also used the American Psychiatric Association DSM-5-TR. I referenced it quite often for the information in this presentation. Thank you.